Hello and welcome to The Connection, where RL Datix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
Hi there, I'm Darren Kilroy.
And I'm Liz Jones.
It's great to be with you again. We have a podcast here which I think you're going to find really interesting, and I'm particularly interested in the content of this one because unfortunately I wasn't there when it was recorded. So tell us more, Liz, about the guest that we're going to hear from today.
Yeah, this is a really great one. We got an opportunity to speak to Peter Carter and to really explore careers actually in healthcare, starting by looking at his career and then thinking about why these are some of the most incredible roles for people who might be thinking of what to do next. I don't want to spoil the conversation, but I think it's going to give people some real food for thought in terms of the trajectories that folks can go on and how much you plan versus how much you open your mind to.
That sort of takes me back to some of my early career decisions. So looking forward to hearing from Peter. Here's the podcast. Hope you enjoy it.
Welcome to the next episode of The Connection, where we look at healthcare jobs and we try and discover how we make sure that there is humanity in technology and celebrate really the great variety of work and jobs. Today, I'm actually joined by Peter Carter. Many of you will know Peter from his work with the RCN, many years advocating and obviously also practicing around nursing. And we're going to have an informal chat about your background. So I don't want to give too much away at the start because I'm going to ask you some questions about your journey, your career, why you're still doing what you do now, and then some of your reflections, if I can, in terms of the workforce today.
Fine, yeah.
And it feels like it's an important time to really do that because we're at the point where there's going to be a new long-term plan. We've obviously got the workforce plan. Presumably those two things will come together. And I'm hoping that some of the people listening to this piece will be people that might be considering jobs in the future in health and care. So can we start with you?
Sure.
So your background, where did it all start and how did you decide that nursing was something for you or was it decided for you?
Well, it was a complete accident. I mean, I didn't know anything at all about psychiatric nursing. It meant absolutely nothing to me. And then an old school friend of mine was trained to be a psych nurse and he told me about it. And I said, God, that sounds really interesting. I said, never occurred to me. And he gave me the address of a hospital. I went off. I was very casual about it and took a job thinking I'd just stop for a couple of months. And I absolutely loved it. My parents, although in later life my mum was to deny this, were horrified. They thought, what? You want to train to be a psychiatric nurse? What's the matter with you? Because they thought I was worthy of so much more. It was just seen
Isn't
as...
it incredible?
Yeah, and I mean, the worst thing you can do to an 18-year-old is tell them not to do something. Anyway, look, I absolutely loved it. I absolutely took to it like a duck to water. And it was enormous fun. I mean, of course, there were tensions, difficulties, and the world hasn't changed that much. You know, sometimes you're overworked, understaffed and all that. But the camaraderie was tremendous. And when I came to the end of my RMN course, I was then working, and one of the senior managers, in those days, people used to refer to you by your surname. It wasn't seen as anything derogatory. Carter, he said, I think you've got potential. So I said, really? And because, you know, when you're like 21, 22, you think, what's he on about? And he said, look, we'll second you to do a postgraduate course in general nursing. And of course, if you got seconded, you got paid. So I was paid as a staff nurse. And in a very casual way, you kind of say, yeah, okay, yeah, without realising this was a golden opportunity. So I did that between St Albans City Hospital and the Institute of Urology. And by my early 20s, I was a doubly qualified nurse in something that at the age of 18, I had no idea about at all. I mean, of course, I knew there were people called nurses, and I'd been in A&E or casualty, as it was called many times.
Yes.
Broken arms and broken nose and God knows what else, cuts and bruises. So it opened up a whole new world for me. And here's the thing that might be moderately interesting, is I absolutely loved it. And I was very heavily involved in the trade union movement.
Is that from the get-go? It was,
I mean, I was a student representative and that sort of thing. And then by my late 20s, I kind of thought, well, you're either going to go down the trade union route which had some attractions, or because I was very frustrated with aspects of management. There were good managers, okay, but I just found it to be so much better. So I jumped ship and went into management. I went to night school and I did the professional exams for the Institute of Personnel and Development, which was 2 evenings a week over 3 years. And I loved it. And then gradually built up and went through the managerial ranks, went to university in my 30s, did a master's. And that's where then after that, I did my doctorate and ended up as chief executive of the Central and North West London NHS Trust for 12 years, which again, I absolutely loved that job. And then I was approached about the job for the Royal College of Nursing. And initially I said no, because I was so enjoying CNWL. And then I thought about it for a while. I thought, well, you've really enjoyed this, and why not do something completely different? And I went into the RCN, had 9 years there, absolutely loved it. And then in 2015, my personal circumstances where the children were all grown and gone, hand off the payroll, mortgage was paid, pension was good.
Yeah.
So I decided to go and work freelance, and that's taken me all over the world. And I've also, on 3 occasions, been asked by the NHS to step in at short notice and chair trusts. So I did 6 months at Medway. I then did East Kent when they lost their chair and chief exec. And then I did North Mid. North Mid was not a hospital that had problems. It's actually one of the happiest hospitals I've ever worked in,
Incredible.
considering it serves a tough part of London.
Yeah.
So that's the story.
And do you know what? You can't get that in a bio, because it's that journey and it's the decisions and it's the moments where you took risk or you didn't, you just sort of found yourself in a circumstance. Really interesting. And one question I've got for you there. So now, these days, when particularly the very younger, the Gen Zs are talking about portfolio careers, or I might do it for a few years and then I might not, so I'll do something completely different. Really, and you're not the first person I've heard say this, you had the opportunity to do that in a career within the National Health Service.
Indeed, yeah.
And to go everywhere, including through to a chief exec role. Do you think that's still possible today?
Oh, look, absolutely. I mean, look, I live and work in the real world, and I know there are tensions and I know there are stresses and all the rest of it. But the NHS is still a great organisation to work for. And one of the things that I think is unfortunate is that there's a very heavy emphasis on the things that are wrong. And I'm not trying to censor it for one moment. Me, of all people, I wouldn't want to do that. But what we're not doing enough is actually promoting what a fabulous career it is. I mean, I'll just stick with nursing, but I could broaden it out. I mean, nursing currently is far too often portrayed as overworked, underpaid, unloved. And you get people saying, oh, nurses go off duty crying, nurses have to go to food banks, nurses, da, 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 da. Now, I know there are some nurses that are struggling. So I don't want anybody to think I'm trying to dilute that. But come on. I work with a number of different hospitals in different parts of the UK, and nurses still express high degrees of satisfaction. People talk to me about they love the job. Now, I'm not at all surprised that there has been a record drop in the number of people applying to be student nurses on, just recently. Yeah. Because if it's constantly portrayed, I mean, if you're 18 years old and you say, I've got to go to food banks, I'm unloved, I'm underpaid,
I agree.
It's awful.
Yeah.
I mean, come on. Now, we've got to promote the good things. And what we don't capitalise on enough is this. By and large, you've got a job for life. Now, I'm not saying that to be comfortable, but in a lot of industries,
there's no security.
There's no security. You've got a final salary pension scheme. Now, I know, again, when you're 18, you're not thinking that, but once you're in a few years, you realise the value of it. There's all kinds of benefits. I mean, really generous annual leave. And the other thing which I don't think that we sort of capitalise on is, look, if you're a nurse, let's say, trained here in Manchester, and let's say you decide, actually, I wouldn't mind going down to work in Cornwall, you can get a job there.
Do you know what?
Or the Outer Hebrides.
Absolutely.
I mean, how many occupations, I mean, you qualify as something, could you literally say, I want to go to Peterborough or Norwich? You can't do that. So what I think we need to do is keep our feet on the ground and be realistic.
Yeah.
But come on, let's highlight the positives. And also, the vast majority of patients still express very high degrees of satisfaction with their care.
And trust.
Yeah,
And trust.
absolutely.
Incredible trust. And you know what? It's so interesting because I think you've just in a nutshell described some of the things where you think the camaraderie, the career opportunities, the ability to travel, some of the security as well. So not to dwell on the negative, but if you could do one or two things, I know there's lots of things that can be better. If you picked one or two that you thought this thing now would make a difference to retention, it will help attract more people into nursing roles, what would your kind of like top two be, Peter?
Well, I know it sounds easy, but most health workers, not just nurses, are not well paid. And I do think that if they had a better level of remuneration, it would aid retention. I mean, look at the number of physios, radiographers, doctors, nurses that go to Australia, New Zealand and Canada, and the pay is better, but so are the working conditions. And in countries like Australia, staffing levels are mandatory.
Yeah.
You know, they're enshrined in law, and that doesn't happen with us. So I know the country's in a difficult economic situation, but there's still a lot of money. And I think it would actually, in the long term, be cost effective to pay people a little bit more. Nobody's asking for some extravagant pay award, but pay them a little bit more. And I think you'll get repaid with more and more people staying, which again, in the long term, is cost effective.
Because you're reducing agency.
You're getting continuity of care, you're getting better care, you're getting commitment. So there's a whole range of kind of spin-off benefits from remunerating people correctly.
As we're now going into another period of, you know, we know that finances are dictating a lot of the decisions currently, as opposed to, say, immediately post-Francis, where there was a question of we have to prioritise patient safety. And productivity has been a big agenda here for the last day. We're here at the summit and everyone's talking about it. At what point do you think that that productivity agenda is disingenuous to the actually, how do we actually attract more people in and keep them? Or do you think that it's necessary? And, you know, what's your view on the productivity agenda this time?
Well, first of all, you mentioned Robert Francis.
Yeah.
The thing that frustrates me about the Francis inquiry is the most central tenet of his recommendations is that a methodology should be developed to ensure safe staffing levels. That has not been implemented. And I said in the post-Francis era where there are all those conferences, I said, I guarantee you the only recommendations that will be implemented are the ones that do not have any resource implications. And by and large, that's true. Because what has changed? I don't think a huge amount has changed. Some awareness has changed. But Robert Francis said, let's devise a methodology that ensures safe staffing. That hasn't happened. Now, in the immediate aftermath of the report being published, the government said, yeah, we're going to implement these recommendations. And they commissioned NICE.
Nice, yeah, I remember.
To work this up. They were well on the way of doing it. They were a year into the work. And then overnight, they were decommissioned. And I remember, because I was at the RCN at the time, speaking to people at the Department of Health saying, look, you've decommissioned this because you think there's a better way of doing it. What's the better way of doing it? And they said, well, we're working on that. I said, hang on. See, you've decommissioned something first before you found an alternative. Now, the reality is, I know why the National Institute for Clinical Health and Excellence were decommissioned, because they were coming up with something that would cost money.
Because they look at it as an economic model.
Absolutely.
That's at the centre of it, yeah.
Safe patient care costs money.
Yeah.
But here's the irony. Safe care costs more, but in the long term, it's more cost effective because you have less serious incidents, less accidents, less things going wrong. So you invest safe.
It's interesting because I think, again, here at conference, we all intrinsically believe that. We're joined by lots of people who work in the patient safety team, statics administrators. But there's an area that we're all currently worried about around maternity care, where it feels like it's at such a very clear surface level, the interplay, and very immediate, the interplay between people's lives and the quality of care and really horrific outcomes, and that interplay with the insurance premiums and the cost of that damage. It's still the biggest expense, isn't it? So do you think the work that's happening now around maternity care and some of the recommendations might be the thing that changes that allows people to have the confidence to look after the finances by looking after the safety?
I'm not sure, is the honest answer. And again, I don't want to downplay that I've read the reports that Ockendon's done, and they are very, very worrying. However, the UK is still one of the safest countries in the world to have a baby. Now, if a bereaved parent is listening to this, they'd say, well, my baby died. And I'm not in any way trying to defend that, not at all. If people have behaved in a way they ought not to, they're culpable and they should be held to account. But I do think we need to get the balance right. Most obstetricians and midwives that I meet, wonderful, caring, dedicated people. So we need to get the balance right about where there are failures. You look into it. Why is it? Are there some individuals that are culpable? And if there are, they have to be dealt with. So I'm not in any way wanting to shelter their people from not being held accountable for their actions. But equally, if people are working in under-resourced services, overstretched, not enough midwives to go around, doesn't surprise me from time to time when things go catastrophically wrong.
Of course.
And when you've got a sick child or a complex pregnancy, a mother giving birth, and if you've got under-resourced and people that are not trained properly, little wonder things go wrong.
Yeah, absolutely. One thought as you're saying that is around the innovation that you see in nursing. So I've always been struck by this. I don't think I've met a more sort of focused, innovative group of people in any area. And so quite often what you observe is nurses will locally see these issues and they'll create solutions. If you're thinking about innovation in the future and you've had a long career and you still see things now, what's your thoughts as we start to bring more of these technologies in that take some of the strain allegedly?
Yeah. Look, we should embrace them. And I think as a society, the British are not very good at these things, not just in relation to healthcare, but in all kinds of ways. I know we probably haven't got much time, but for example, the videotape recorder, which younger viewers and listeners will say, what the hell is that? But that was a British invention.
Yes.
But no one saw the potential. The Japanese never invented it, but boy, they saw the potential and it swept the world.
Yeah.
Now, with things like artificial intelligence, don't fear it, embrace it and say, how can we take this on in order to take forward clinical practice?
Yeah.
And the whole of the digital world, we are data rich and knowledge poor. I mean, that's an absolute fact. Most trusts collate all sorts of stuff. Where does it go?
Where does it go?
And they would say, look, we're so busy, we're so overstretched. So we've got to engage with the digital world, the whole world of technology in order to take things forward. I mean, the thing the UK underinvests in compared to places like Poland, Slovenia, Bulgaria, let alone France and Germany, is on scanners. In most of those countries, per head of population, they have far more scanners than us. And a GP can make a direct referral for a scan. I have a friend who lives in France. They went to a GP in the morning. In the afternoon, they had a scan.
Yeah, I've heard the same in Iceland.
Yeah, it can't happen in the UK.
Yeah.
And yet, by doing that, what happens is you get the early diagnosis. Sadly, we have some of the poorest outcomes for cancer compared to France, Germany, Italy, and Spain. Why? Because in those countries, you get the early intervention and the early diagnosis. So again, I know it's a cliche and I've said it already, you invest and in the long term, you will save. You'll save lives, but you'll also save money.
Absolutely. And we're obviously getting to the end of this now, and I feel like we're just warming up and we could carry on. But I guess I wanted your reflections in terms of the education of nurses. It wasn't that long ago we were talking about how horrendous it was that the bursary had been removed. And what do you think? And again, we're really interested in making these desirable careers. What's your thought in terms of how the future plan should deal with the education of nurses in this country?
I'm a huge admirer of the work of Alison Leary. About where Alison and I may have a slight sort of difference is that I believe that we should do more to encourage the apprenticeship route. Not because I'm in any way anti-degree educated nurses, not for one moment, because the evidence is quite clear that you get better outcomes. But up until the bursary was scrapped, the average age of a student nurse was 28 years old. And then George Osborne comes along, scraps the bursary. So it meant that mature students could no longer afford to enter it. And 90% of nurses are women. And a typical profile of a mature student, women in their mid, late 30s, early 40s, would be someone that perhaps didn't complete their education at school, didn't realise the potential, don't necessarily have the A-levels, the GCSEs. Just because they haven't got their paper qualifications doesn't mean they don't have the intelligence. And when there was the bursary, mature students, they made excellent nurses. That dropped like a stone. So what I'm a believer in is you need the mixed economy of entry levels, not in any way to dilute nursing, but in my opinion, it will enhance and take nursing forward.
Perfect. And that's what we want to do. We want to take nursing forward.
Indeed.
It has been such a pleasure to chat to you. I honestly think we've got to the tip of the iceberg of the conversation, but it's been brilliant to catch you whilst you're here at Summit. Thank you once again.
Thank you.
And I look forward to seeing more of your great work and adventures in all the trusts and across all the different countries.
Well, thank you very much. And thanks for inviting me.
Thank you.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit rldatics.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RL Datix team, thanks for listening.